This is Chapter 29, Child with Musculoskeletal or Articulation Dysfunction, Part 4, and we're talking about amelia, which is the absence of an extremity. So this is not an extremity that was lost in some sort of an accident. This is being born without it. So that's amelia, being born without an extremity. Meramelia is being born with only part of an extremity. So you may have seen somebody who has an upper arm, but they're missing the forearm and the hand, something like that. Phocomelia can be described as a seal limb. This means they're missing or have a very small part of the long bones, but the hand or the foot are pretty well developed. So it looks like off the shoulder all they have is a hand, or off the hip it's the foot, but the foot or the hand are pretty normal sized and shaped. Sometimes this can be, we just don't know why, sometimes it can be an amniotic band. So in utero, a piece of scar tissue gets in there and wraps around the limb, and so it's not getting blood supply out to it, and so it doesn't develop. Teratogenic medications, if they're given in that first trimester as the limbs are developing, can cause this. There really is no treatment other than prosthetic devices, and the earlier we get a child used to using a prosthetic, the better. Osteogenesis imperfecta, also called brittle bone disease. This is genetic. It's passed on. It's hereditary, but there are many different types. The most common is also the least severe. So this is autosomal dominant. So one of the parents has it and passes it on to the children, or to half of their children. You only have to have one gene for it and you will have the disorder, but it's usually not overly severe. There's other forms, the autosomal recessive, and this is where both parents are carriers and are going to pass it on to a quarter of their children will end up with it. That is the most severe form. So the pathophysiology that's happening is it's related to the collagen, the structures that build and support the bones. They don't produce normally, and so their bones are very brittle. They break easily. So they get fractures. They're going to develop osteoporosis and skeletal deformities because of this. Usually once they're fully have reached their adult height, which is not going to be normal height usually, then they're going to get less fractures. So usually after puberty there's less fractures. The main treatment is just trying to prevent fractures. So particularly if it's a severe form, we're going to treat this child very carefully, very gently. Ask the parents the best way to do diaper changes or to turn them, do things. A child who has this, some of our goals are going to be to prevent contractures and deformities, avoid that or prevent muscle weakness and osteoporosis, try and work on normal mobility and alignment of the joints. There are not a lot of drugs that can help this, and if a child has multiple fractures, it's worth ruling out osteogenesis imperfecta. Most of the time it's the mild form, and so these are kids who can still run and play and act like normal kids, but they are going to break bones more easily, so we probably don't want them climbing trees. We'd rather have them, jumping rope. We don't really want them doing contact sports, but they can do swimming. So we're going to have to let them be normal kids, but try and minimize the risks for breaking bones. Legg-Calvé-Perthes Disease. This is self-limiting, so it doesn't go on forever. It will get better, and it's idiopathic. We don't really know why. A lot of thought is that it has to do with kind of overuse, but we don't know. Usually happens well, between 3 and 12, but most often it's boys between 4 and 8 years old. So it's avascular aseptic necrosis of the femoral head. So that ball of the femur has issues with blood supply and dying, but it's not from germs, right? Avascular but aseptic necrosis. So there's 3 stages. That surface of the femoral head gets flattened out. Then we get vascular reabsorption of the epiphysis, which is the end beyond the growth plate, and then finally we get regeneration. So the treatment for this is rest and non-weight bearing. I said some thought is that it could be overuse of repetitive, the same movement. So resting it, non-weight bearing, let it heal. In severe cases, they may need to do some traction or surgery to pin things in place, but usually it's just rest and non-weight bearing. Most of the time, by the time it regenerates, we have a normal femoral head again. But if it was really severe, damage can be done that is beyond what the body's able to fix, and permanent damage is permanent. A slipped capital femoral epiphysis is surgical. This is not something that will run its, you just stay off it and let it get better. This requires medical attention. So this, we have a spontaneous displacement of the proximal femoral epiphysis. So the end of that ball of the femur slips off, and it usually is going to go posterior and inferior. This happens during adolescence, during that growth spurt, so between 8 and 15 years. So it's right before or during adolescence. That femoral neck slips, and so we end up with a deformed femoral head. It's going to yank on all the blood vessels, so it doesn't get good blood supply to that, which can then do further damage to the femoral head. So we want them off of it, bed rest until they go to surgery, and then they're going to go to surgery and put pins in there to get that ball of the femur held back together the way it should be. So spinal cord or spinal column malformations. We have kyphosis up here in the thoracic region, lordosis down here in the lumbar region, and scoliosis is kind of a lateral twisting, and that can be either thoracic or lumbar. And if you have the child bend forward, when they bend forward and come up slowly, when they get to the area where that scoliosis is, you'll see this abnormal hump on their back. So here again is the descriptions. Kyphosis up in the thoracic, lordosis is lumbar, and then scoliosis, that twisting. And you can see that little girl has scoliosis. So how do we diagnose scoliosis? Well, what the physician is going to do is x-rays and actually measure how much of a curve there is. What we can do as a nurse to screen for this is we have the child bend forward like they're touching their toes and then come up slowly, and we're looking at that spine to ensure that's straight. And if we see that hump, there's a little thing that you use to measure how much of an angle that is, the hump, and then we refer that to the physician. We also look at symmetry. Are their shoulders the same height? Are their scapula the same height? Does one stick out more than the other? The hips, are they the same height? Treatment, our book talks about bracing, and that doesn't seem to be done a lot in our area. It seems like they just do x-rays and watch it, and then if it's bad enough they go to surgery. But they can do bracing, they can do some muscle strengthening, teaching them exercises to try and strengthen those muscles. But If it doesn't improve, they need to do surgery. So here they do the x-ray to actually measure how much of an angle this is. And it was 78 degrees, and they put in rods and got it down to 15. So this is the stuff they're using. They're putting in rods, and they're literally screwing them into the vertebrae. There's usually some fusion of some of the vertebrae that they have to do, and then the rods as well. Osteomyelitis. This is an infection of the bone, and sometimes those germs get directly in there, and sometimes they were somewhere else and spread. They get into the bloodstream, spread, and settle in the bone. Doesn't really matter either way. We're going to treat it the same with IV antibiotics. So we're going to watch for this. We're going to be looking at our labs for that elevated WBC and increased the SED rate and CRP. You've probably figured out at Children's we love CRP. It tells us our immune system has been turned on. It goes up quickly and it comes down quickly when you get the right treatment going. We're going to see at the site the child's going to have a temperature. They're going to have tenderness at the site, swelling and warmth at the site, and it's painful where that osteomyelitis is. We're treating it with IV antibiotics. The most common germ is staph. In infants, it may be our group A beta hemolytic strep, but this is at least 4 to 6 weeks of IV antibiotics, and depending on the germ can actually be longer than that, which means we're probably putting in some sort of a central line, like a PICC line. Initially, we don't want them weight-bearing if it's the leg where the site is, because partly it's just really painful, and we don't really want to be disturbing those germs. With kids, you can almost always fully kill osteomyelitis because their bones are still growing. There's still blood flow through the ossified portion of the bones. They say with adults, you can almost never fully kill an osteomyelitis because they no longer have good blood flow through that ossified portion of the bone, where the infection is. So with kids, the good thing is we can usually fully kill it, but it takes a long time. Juvenile idiopathic arthritis. We used to call this juvenile rheumatoid arthritis. Now they call it idiopathic because we don't know what it's from. It may be autoimmune, it may be environmental, but we don't really know. Peak ages for this are between 1 and 3 years, and then again between 8 and 10 years. And arthritis, right, inflammation of the joints, this can range from severe to very mild, and the mild often kind of seems to flare up and go away and never come back, but the severe form can last, be a chronic thing, or some of the kind of in the middle there, a medium one, can go away, but any joint damage that's done is permanent, right? The damage won't go away even if the symptoms do. So what do we see? Stiffness, swelling, loss of mobility, a joint that's warm to touch, but it's usually not red. So it's not an infectious thing. Sometimes it's going to be tender. It happens before age 16, and that's how they diagnose it. Has to have the onset before age 16 in one or more joints, and it lasts at least 6 weeks. And then they work up everything else and say it's not some other form of arthritis, so we're going to call it juvenile idiopathic. There's not really a specific cure for it. Our goal is to preserve functioning because the damage to joints can be permanent. So we want to prevent that joint deformity. We want to relieve symptoms because it is painful. Often there's some involvement of the eyes, so we want ophthalmology involved. We want physical therapy and occupational therapy working with these kids so that they don't lose mobility. We are going to try meds. First, we're going to start with those NSAIDs, and if those don't help, then they're going to move on to the other things. But often these kids get through it, the joint gets better, and they're done. It doesn't necessarily come back.